Thank you, Michelle. That was a very appropriate way to get these proceedings started. We're very excited with the new targets that UN is pursuing, and as Michelle said, if we remain highly focused, we should be able to make a difference within a matter of a very few years. To explore these issues further from the perspective of how to move the science to policy and implementation, we'll move to the 90-90-90, the final treatment targets towards the end of the AIDS epidemic session that is going to be moderated by Lord Norman Fowler from the House of Lords. Without further ado, Lord Fowler, the podium is yours.
Well, now, I think the first thing to do is get a panel here. Otherwise, I've got to fill in for 45 minutes, which would not be good for you or for me. Now, where is it? Michelle, you're up here again. You're on this panel. And I've got the Minister of Health from Malawi. Minister of Health. Have I got a minister? And the Minister of Health for Swaziland. I'm fine, thanks. Good morning. And Dr. Deborah Birks. Where's Deborah? How are you? Good. You didn't think you were doing two, did you? Gordon Campbell. No. Oh, what? No. You?
No, we're good.
Well, if we are short of chair, you won't.
Okay.
Gordon, where's Gordon? Gordon Campbell, anywhere? Okay, and Mr. Kenley Sikwezi. Have we? Yes, here we are. Good. Right. Well, I think we've got a panel. We've only got 45 minutes in any event, so I think that's going to be quite a challenge. Let me tell you what we're trying to do in this session. What we're trying to do is to really work out and be guided on what the new targets mean, what they mean for a government, for UNAIDS, for donors, and for patients. So that's quite a long thing, period for a big canvas for us to fill in the available time. Perhaps I might introduce myself in this very distinguished group. You might say, what am I doing here? I'm not a clinician. I used to be a politician. I used to be a minister. But I'm not even a minister anymore. But I am vice chairman of the all-party parliamentary group, and most of all, I've just written a book on HIV/AIDS. I thought I'd mention this. It's just come out, and it is based upon a series of visits to 9 cities around the world, available on Amazon. So there we are. If anyone from Scotland is here today, you probably still have got time to kind of get back to vote and listen to most of the session today in any event. So let us begin. Michelle has been speaking. I think, Michelle, it's asking a bit much, but do you want to start? What do the new targets mean for UNAIDS? Now, I must say we've only got 45 minutes, so I think it's 5 minutes each, I'm afraid to tell you. But have you got any observations on that?
No, new targets. Again, like I said, for us, we need to bring a sense of accountability. We need to make sure that the world can be inspired by something which they feel they can deliver on. And like I said, it is not just about numerical number, 90, 90, 90. What we were trying to really push is to make sure that we bring, honestly, the people at the center of our approach. And by pushing 90, 90, 90, we're thinking about the people who have been left behind. We're thinking about those 18 million people who were not reached by treatment, people who are suffering in silence, how to give a voice to them. And if you look at all the information we were gathering, we realized that we are failing completely to even test people. 19 million people out of 35 million people were not knowing their status. So how to really deal with this first challenge? We realized from all the index analysis we have been doing in different places from China to Lesotho that people were not knowing their status for different reasons. The first one is that stigma discrimination still there. People are still scared. People don't have access to services like they should have. And they are not going there for many reasons. We said also, we realized that probably our testing approach, which were valid at the beginning of this epidemic when we are not knowing much, maybe are not the best one today. Maybe we need to change that one to really go for more community, family type of approach, like I was saying. Maybe also our tools, scientific tools, were not the most adequate. Maybe it's too costly. So I think for me that was the first one. The second one is that how to test people and not give them treatment. Why? What is we need to do differently? That's is for me again is population location. I like this too. We need to know where people are, how to reach them, how to make sure that treatment. But this treatment, we need to start thinking about second line, third line, and thinking about long-acting treatment, not being just believing that the first line, which were there in some part of the world for 15 years, will continue to work without resistance, without, so we need to bring all those debates around. So it's a change completely in the way. And finally, we know that if they don't suppress the viral load, if they are not, that is the closest we have for closest to cure. And we know that will not happen if we don't change also our service delivery paradigm. And this service delivery paradigm we are talking about for so long, how to really improve the interface between community and the last provider of services, creating demand, tapping on non-conventional capacity. If we don't do that one, it will not work. So for me, it is a new way to completely think about equity, dignity, and engaging certainly private sector and other partners in a new agenda, a new adventure.
Thank you, Michel. That's very good. So let's go on, and let's go on to government. Shall we go on to government next? And perhaps we might ask Dr. Jean Kalilani, the Minister of Health for Malawi, to give us her views on it.
Thank you very much. Definitely we are ready to give our views on this. The concept of ending the HIV epidemic by the year 2030 is a very welcome development by many countries, including Malawi, and partners, including politicians. I am one of those. I believe we know effective measures that would end the HIV epidemic, as we have been hearing this morning from Michel. HIV treatment has shown a remarkable impact on lives of people living with HIV and on rates of HIV transmission. let us all put our efforts in scaling up treatment. Malawi in particular supports the ambitious 90-90-90 targets that have to be achieved by the year 2020. It fits well with Malawi's national policy on universal and retroviral therapy for all infected HIV-positive, pregnant or breastfeeding women, TB patients living with HIV, and under 5 children who have been identified with HIV infection. Malawi is also considering universal treatment for other populations living with the virus, for example, discordant couples. As we seriously focus on these targets, we clearly need to think of what it will require of us to achieve them in the prescribed time frame. Areas of consideration include country ownership as well as political will, required commodities to do the job, specifically human resources to test, treat, and follow up clients, technologies and equipment, especially in viral load testing, models of managing the sick and those not sick, records keeping for effective planning and program management. Roles of communities very important in promoting adherence and other relevant areas. It is clear that collaboration is still key if we are to attain our set goals. Allow me to indicate great appreciation on behalf of Malawi government that is led by the State President, His Excellency Professor Peter Arthur Mutharika, for respective and joint roles played by the Global Fund, PEPFAR, UNAIDS, WHO, and many implementing agencies. Indeed, we have done a lot together. Let us keep on doing it together, because together we can conquer this HIV infection. I would also to specifically thank UNAIDS and IPAC for organizing this very important, meaningful conference, and especially for inviting Malawi to share this platform. Special respect to the UN Executive Director, Michel Sidibe, for sharing a moment with us to discuss few issues relating to my country, Malawi. With these few remarks, I sincerely thank you all for your attention. Thank you.
Thank you very much indeed. And perhaps after Malawi, we can now turn to the Minister of Health for Swaziland.
I think it's working.
It's working. Yeah. Thank you, Chair. And may I just greet everybody here. I want just to take us through to say, is it practical why are we now going for 90, 90, 90? Why are we saying as countries we are ready to roll out this? In fact, starting from what are the problems that we are encountering with now the normal way we roll out the treatment. In fact, there are problems in the fact that we are waiting for those tested HIV positive to reach a certain, like in our country, we start giving people ARVs when their CD4 counts are less than 350. But by that time, they would have, some have got even showing like there is also a core infection like TB. All people that have got TB, most of them, 80% are HIV positive. Now, delaying the treatment would mean that we are opening a hole for other diseases. Also, to say we as a country, and we as a country, Swaziland, we are ready to roll out treatment for all those that are tested HIV positive. Why? For the past years, from 2001, we started initiating prevention of mother-to-child transmission. And we also started to say all women who are pregnant and tested HIV positive start treatment, no matter what is their CD4 counts. And this has shown a capacity of that we can roll out for even the other group. And also the fact that for our HIV positive children, they are already in treatment. But now the question is, what about those that are HIV positive that we test and we just give them the information that you are HIV positive, wait for your CD4 counts to be less than 350, and then we start giving you treatment? Really, we end up having defaulters because there is nothing tangible. There is nothing which one can say, hey, why do I have to test if maybe we are waiting for a certain number? At the moment, we are, as a country, we are giving the ARVs are, the government of Swaziland is buying ARVs that are used in both public facilities, hospital, and even on private facilities. So, meaning that the country, the government commitment, and also the political commitment is also ready if support is there, so that we'll make sure that we will reach everyone who's also HIV positive. Again, if you look at the size of Swaziland, Swaziland is a small country, a country with 1.2 million in population, and hence it's easy to move from one corner to another corner and then you go back the same day. What is the advantage of that? Meaning that to roll out this, to pilot treatment as prevention to the country, it's very easy. And the fact that we've got capacity in place whereby out of 133 facilities, 117 are now initiating and also refilling ARVs. Those left, which is about 16 facilities, we are now still, there is ongoing capacity building so that we make sure that 100% in every facility there is human resource responsible to support the rollout of ARVs. One can also quote that when the Parliament opened this year, His Majesty the King emphasized the importance of HIV-free generation. If we say HIV-free generation, it means that we must make sure that we go for 90, 90, 90, so that we will reduce the infection. And we do, not only on the trained or professional that are rolling out the program, but also we've got in each community rural health motivators who are based in different communities, who are doing the voluntary work, who are doing door-to-door, giving information to the people. Now, we want to make sure that we also promote door-to-door testing so that there will be a support at household level, whereby if a young girl is tested HIV positive, there will be a support from the father, the mother, and even the siblings, because it will be a door-to-door, a face-to-face, a family approach, whereby the support will be there. And again, checking my time.
Not the king,
Checking my time. And again, one has to say, we have lost, there are a lot of defaulters because of what we're doing now. Just testing people, telling you that you are HIV positive, your CD4 count is 700, wait until it's less than 350, then we'll start treating. We have seen it is not working unless we make sure that every 90% of those we test and they are HIV positive, we start the treatment, we'll yield a positive reward. I would also want to invite even the donors to say, if you want to see the value of your money, make sure that you support this initiative. We are ready to roll out it. And we, not only as a country, but there is both political commitment, the leadership, which is the king, and also the people of Swaziland in different aspects. So you are welcome to support us, and we are really ready to roll out this. I thank you.
Thank you very much. Well, I think that leads on naturally to the issue, the response of the donors and their view. And for that, Dr. Deborah Birks, who's, I think, very well known to you in any event, who's now the Ambassador at Large and US Global AIDS Coordinator in Washington. Deborah.
Thank you, Lord Fowler. I'm just inspired by the ladies at the end of the table. Thank you. So we strongly believe in UN AIDS Declaration of 90-90-90. And we have tried to translate this into a way that makes sense to us. So we now call it the right things in the right places at the right time. And to all of you in the audience that actually showed us what the right things are. And this shows how important that intersection between advocates, activists, and scientists are. Because we have most of the right things tools right now, and we know what they are. We just need to have the will to implement them. And I just heard tremendous will to my left. So I think that's really quite extraordinary. So we also have to be honest where we don't know what the right things are. So we've gotten, I think, the right things for prevention of mother-to-child transmission, voluntary medical circumcision, ART as prevention, condoms. But where we don't completely know what the right things are is some of our more vulnerable populations, and particularly young women. Those of us who raised female children, now that mine are older, they now tell me that I didn't have any of the right things. So now that they're 27 and 31, I get the details of what was going on between 14 and 18. Quite scary. And so I have to admit I was not great with the right things in raising my two daughters. But I think we have to know where we have clear evidence, and we have to know where we don't and seek that evidence. Right places. Well, this is where it gets quite sticky, and I'm incredibly awed by the leadership that has occurred around the right places. To have Malawi go and do B+ when everybody was still questioning that judgment it's such a bold vision. It said that mothers matter. Mothers matter as much as preventing infection to their children. And I think that call to action really changed how mothers in the community viewed, how they were valued, and how their children were valued. And the impact of that bold move not only provided treatment, life-saving treatment for mothers, independent of CD4 cell count, but it also said to mothers, if you come to the maternal child health block, there's something for you and there's something for your babies, and it increased the number of visits for mothers, for children under 2 months and children 2 months to 2 years. Really an extraordinary outcome. Uganda, when I see David Sawato out there, Uganda, when they saw their data of increasing incidence of HIV, provided the bold leadership to look at everything again and really focus on where HIV was and where it wasn't. And I'll show some of the graphics, the amazing impact that they've had. Kenya just recently doing a complete analysis of saying we have HIV is primarily in 10 counties, and we need to focus on those 10 counties. South Africa recently did that same analysis and said we have 52 districts, but HIV is increased in 13. So that kind of really fundamental focus and the leadership that takes to say HIV is here, it's not there, it's not everywhere, and 90-90-90 must translate into where HIV is in order to control it. And then finally, the right time, and I think this allowed us to reflect back and say, in that evidence base of the right things, are we reaching 90%? So if you look at TB HIV, are 100% of the TB HIV patients on treatment? No. Are our children on treatment? No. Are the adults in the highest incident areas on treatment? No. So this right timing piece becomes absolutely critical, and I'm so inspired by Swaziland saying that we want to do this. And I just want a quick comparison between Swaziland and Kenya, and the fact that it has to be a country-specific discussion. In Swaziland, thanks to WAFA, they have data in partnership about the number of women who have HIV infection that have CD4s over 500. So in Swaziland, it's almost 60%. Their epidemic is very different and still what I would consider very hot, a very ongoing epidemic. If you look in Kenya, 65% of the patients are under 500. So it's an older epidemic. It will need a different focus. So a test and treat strategy may be absolutely essential for epidemics that are still expanding, where the majority of the HIV positives are over 500 and still need treatment in order to have low viral load. And in Kenya, it may be a different reality, but using data effectively for decision making will be extraordinarily important in our current resource environment. Because we have been blessed. We've been blessed with amazing resources over the last decade. And now we have to show all of the politicians and all of the countries that we are going to focus those resources in a way that will have maximum impact. I just want to finish with the issue of stigma and discrimination because I am so absolutely want to endorse everything Michelle Sidibe has said. Looking at Liberia, Sierra Leone, and Guinea, one sees that the communities have said, if there is nothing for us at the health center to treat us for Ebola, why would we come forward? So it's the same with HIV, and I hope it reminds us again that if people feel like there's not services for them, or if they feel like when they get to the health center, they're going to get, why are you asking? Why do you think you're at risk? I mean, that kind of discrimination that occurs in that first visit will resonate back to the community that there's no reason to come to the health center. We're not welcome there. And I think if any of us aren't welcome at the health center, all of us are unwelcomed at the health center. And we have to continue to focus on these issues. And I think we should use the issue of Ebola, which seems to be something that resonates with everyone, to re-emphasize how it's important that our health centers and our public health approach is non-discriminatory.
Thank you very much indeed. And lastly, from the point of view of the patient, Kenley Sigwezi.
Thank you, Lord Fowler. Once again, it's really a privilege to sit in this panel for the second year running. I thought I had offended enough people not to be asked to come back. So, but I do really feel privileged. There are a lot of many more able people living with HIV across the globe who would have sat in this chair and probably much more deserving than I am. But while I was thinking about what to really say about the new targets, my thought pattern was somewhat disturbed in a conversation that I had just prior to this meeting, where I was asked whether we are really going to buy into the idea of ending AIDS. And somebody said, Kenley, do you really want to speak about ending AIDS and supporting these new targets? And I thought it was a trick question. But I thought about it and I said, yes, I really do. Because if we're not aiming to end AIDS, then what are we doing? What are we aiming for? If HIV does not end with me, and sort of my children, my children's children are free of the risk of HIV, what are we doing? And I really realized that I needed to begin to believe that we must, at all costs, begin to work towards that target. And I think this to me, of setting the 90-90-90 new targets is an important step forward. And I remember many years ago I used to read a lot of papers written by important people. I think it was Roosevelt who said, in fact, to the effect that if you don't set a target, in a way you are setting some target, either to achieve something or to do nothing. Either one of the two is a target. And really, if we really think about that, then what is the alternative? And I think what Roosevelt seemed to me to indicate that in any situation, the best thing you can do, first of all, is the right thing. So we must ask ourselves, what is the right thing to do in these circumstances? And I think the people that have spoken before me have ably indicated where we need to go, the populations that we need to be targeting, the type of approaches we need to be developing, the human rights framework with which we need to approach our retargeting framework. And so it is the right thing to do. Or the next best thing you can do is at least do the wrong thing. And we learned this, that when you start people at low CD4 counts, at 200, that this doesn't work. That is too late. So at least we did something. It was the wrong thing, but we learned something. And so we revised that and, are approaching HIV treatment from a different perspective. But the worst thing that we can do is do absolutely nothing. That is, if we continue with the status quo and continue to run with the mill and not setting any realistic sort of goals that we can achieve to reduce the impact of HIV on our populations across the globe, is the worst thing that we can do. So I'm really excited about the 90-90-90. But I also want to say to Michelle, I really think it is still too low. Because if we're really only targeting people, 90% of people we test, that is really a low target. I wish we could really just target 90% of people that are testing positive and then aim to virally suppress them. Then we'd really be reaching some really, for me, an exciting goal by 2020. It's easy for me, I think. We already have low-hanging fruit. We already have people in our care mechanisms, as the honorable ministers have said. We have people who have been waiting on treatment. And so we already know who to target. We already know the populations where the epidemics are exploding. And so at least we have somewhere to start, and we're not starting from nowhere. But what will also be critical is that we move very quickly. And given our weak health systems, it means that you're going to have to come back to me and ask me, how do we best deliver these services to me? And I can guarantee you that with the current care systems, at least where the epidemic is highest, we will not reach 90-90-90 or 20 by 20 without involving the communities. Communities are going to be very critical in delivering these services to their peers, and communities will be able to inform how best these services are delivered. I think the holy grail of healthcare services being the preserve of physicians and clinicians and so on, that era is gone, is long gone. I mean, I was laughing when a researcher said to me, Kenny, we used to freak out if we sat in a meeting with a social scientist. You know, and so I'm saying to you, well, I hope you don't freak out when you have to sit in these meetings with us. So you involve us fully, and rightly so, as Ambassador Brexa said, we don't have an Ebola situation. Lastly, I would just like to say that the important thing to do now is to begin to set a strategy today, that we begin to know what we're going to do tomorrow. Thank you very much.
Thank you very much. Good. Well, thank you very much, all the speakers who've kept admirably to time, which allows us just under 15 minutes for questions, points, anything anyone wants to put from the audience. Who would like to start? I think there's a microphone there, isn't there? Yes, there is. Can't believe we're going to take coffee 10 minutes early. No. There we are.
Yeah. Hello, good morning. My name is Ana Maria Bejar. I am Director for HIV, Eastern Europe, Latin America, and the Caribbean of the International HIV/AIDS Alliance. Thank you so much for sharing your thoughts. Having started reading Lord Fowler's book, I would recommend everyone to have a look at it. It's a really interesting recount of many years of engaging with the HIV epidemic, and also a recount of his trips throughout the world. So it's really interesting to read. My question is to Deborah. And although I think we all agree that we need to invest the resources where the epidemic is and where the greatest number of infections are, I would like to know what's the vision of USAID and PEPFAR on sustainability and on responsible exit strategies. We are recently seeing different programs around the world being cut or being closed down with 5 weeks notice, or with not enough time or activities to make sure that the countries where USAID used to have investment are able, the governments are able to hand over these programs, and consequently people affected by the epidemic that currently receive services not getting them very suddenly in the very short term. And I just want to give the example of the Caribbean, which has just happened 5 weeks ago, and where we have a region where homosexuality is criminalized, and where resources are being redistributed across the islands, rightly so. But my question is more about how to handle that change that we're seeing happening very, very drastically at the moment. Thank you.
Michelle, do you have any comments on that?
It was addressed. I have a comment, but I think it was addressed to Debbie. So.
Was it? I beg your pardon.
Yes. No, but he should answer. No.
I can answer.
Come on, you're shrinking violence on this thing.
No, it's a very important question.
Speaking both at once. Right, go on.
I think you're raising two issues. One, when you have to refocus to where the epidemic is. What happens in the communities that do not have HIV but have been utilizing HIV money for a broader agenda or for issues related to HIV but other things? And I think also in your question, but I think is middle income status. And what is our bridge between lower and lower middle income status countries and middle income status countries, and where will that bridge come? Because the issue is so much broader than HIV, and I think each of these communities need to start raising this with Gavi and Global Fund and PEPFAR and the World Bank and the International Monetary Fund for where is the concessionatory loans for health when countries abruptly achieve middle income status, and what does that transition look like? And that really has to be a high-level discussion above my level, but we should start that discussion. I think it's absolutely key because some of the changes in Latin America relate to the middle income status. We had the countries come back to Washington from the Caribbean Basin for very specific discussions, primarily related, are we doing everything that we can to combat stigma and discrimination in the Caribbean, to ensure access to services. And it was my personal impression that we could do more. And so we did have the Caribbean, Dominican Republic, and Haiti come back for really comprehensive discussions around that and how they could, in our resource environment and envelope, refocus resources to address those core issues to ensure access for everyone on all the islands. And there are some islands that do not have HIV. That is a good thing. It is a good thing that HIV is not everywhere, and it's not everywhere. And really, I hear what you're saying about transition time, and because the budgets, these countries, not to get the details, still have 13 money that can be utilized to phase out, while the 14 money is used in a more focused way. We're a year behind in our money, if you wondered why 14 is just going now into 15. So that's a long answer about focus, but if you have concerns about the speed of transition, please write me, because there's no intent to be arbitrary and not have a smooth transition for some of these prevention services.
Thank you very much. I mean, there's a particular problem with the Global Fund, I think, and Ukraine at the moment. I mean, it just sort of highlights some of the problems you have, where you have a middle-income country or low-middle-income country, but obviously up against the most difficult political position at the moment, being told that they must increase the amount of money going in, but also being told they must increase the amount of money going to other things. So, I mean, I haven't got a solution, but it's a remarkably difficult issue. Another question. Yes.
Can I just speak?
Yeah, you.
As a politician.
There's a microphone for you.
I would like to be a little bit provocative. My name is David Soda, Macquarie University. 1990. I remember myself soon after graduating many years ago, and we were looking at emerging epidemics, and we said, what will be the next emerging epidemics in the next 30 years? And subsequently, after 10 years of graduation, we have a meeting about what are the next emerging epidemics. Guess what? You know, malaria, tuberculosis is still with us. I bet you it will still be with us as a big problem in the next 20 years. So I'm thinking, what has come into the calculation? What is new? What is going to impel us to be able to do the 90-90-90 that we haven't been able to achieve with these other diseases?
Now, I hesitate to actually ask anyone first, but I think, Michel, that is for you. Don't you think so?
Yes, I think I wanted to react first on the first question, because I personally believe it's a very important question. If you look at the data we have today, the projection, in 5 to 10 years down on the road, we'll have only 13% of the new infection occurring in low-income countries. So we'll have 87% of new infection will happen in middle-income countries. So what we will do? So it is very important issues. It is calling all of us to think about what should happen beyond ODA, what should happen in terms of new criteria for allocating resources if we are facing those type of crises. If you look at what happened today with Ebola and others, it's also calling us to think about the architecture, global health architecture. Is working, is not working, what we should do. So we face, for example, with Ebola emerging epidemic, probably the problems, where to get the money. Maybe we need to reflect on those issues in more profound way, and AIDS is showing us the light on that one. 1990, a new calculation or old one. I think personally what is very important for me is to galvanize the world, to demonstrate to the world that we can do more for people who have been not reached with our services. And to galvanize the world, unfortunately, the only things I saw which inspired people is clear targets, is to make sure that people can measure what they treasure. If you don't, you're not capable to measure what you treasure, it will never happen. People will always think about, okay, let us have everyone everywhere to have access to medicine. Yes, why not? That is our dream. That's what we call 0000. But if you want to reach 000, if you want to control the epidemic, if you don't have a milestone, if you don't have a clear targets which can mobilize people, which can galvanize, again, we have pharmaceutical firms and others in this room, why they will continue to invest on this? We are seeing already drops in India. People, we used to have 24 companies producing generics on AIDS. Today, there are maybe 3, 4. So you need to create a new momentum. So every single constituency will find interest to go for it. That's why I personally feel that 1990, it is a new movement to bring people-centered approach to save life, but also to change our delivery approach, bringing community like we talk about it, and trying to also change the way we program and we prioritize. Because, and for me, I think it will create that. It's not just a magical calculation, but it's something which can be done and something which will save millions of lives, and people can see it around them, and they can see that. And it will bring probably long-acting treatment, probably. And not only maybe for AIDS, maybe for even people who inject for insulin deficiency or whatever it is, diabetes and others. So for me, it is trying to regalvanize the world to show that before 2030, 2020 can be a critical milestone to achieve more for people who are not reached by our services.
Okay, one last question before the break. Gentleman next door, I think, or is there anyone over on that side? No? Right, okay. Can we do that?
Ania Żakowicz, AHF Europe. Thank you very much for the push to revitalize the movement and also getting treatment to people, and of course scale up testing. But I wanted to ask, because we have a strategy, but I wanted to ask about specific steps in terms of key affected populations, because we have estimated number of 16 million people who use drugs, 3 million people who live with HIV, and 4% of them have access to treatment. So I wanted to ask about specifics. What are the next 3 steps UNAIDS wants to do to increase the coverage and also increase access to testing?
Sounds like you again.
David, do you want to reply? Now, the first strategy was to put light on those people who were left behind. It was the first time that we produced this gap report. It took us a lot of time to make sure that those people, forgotten people, are really identified. The second strategy is certainly to have a better tailored approach in terms of targeting specific groups in function of, like I said, specific location. You don't have one epidemic. The report is clearly showing us today that you have a multiple epidemic. You cannot talk about epidemic in the same way like we were talking about a few years back. So we need to bring this specificity. And the third strategy, unfortunately or fortunately, I can tell you, if we don't engage politically, if we don't have a political approach in terms of dealing with people left behind, you will never succeed. It is not about technical issues. It is not about just knowing what we do or what we don't do. We know that in Russia, in different places, but we know that if we don't have a new strategy to engage a politician, to be able to understand that no sustainable society will be there, no stable society will be there if you exclude the people and make them accepting that and working on it, it will not happen. So our strategy today is to, personally my strategy is to work more on the politics than anything else before. Trying to really commit my energy, my time to make sure that we can really bring politicians to pay attention to policy reform, to pay attention to law reform, to pay attention to the fact that investing there will have a major return for them for their election. If we don't have that one, I don't think it is just a technical argument which will make things changing in those places. And the first challenge was to be in meeting in Moscow when I received more than maybe 500 letters that I should not be there. And most of them coming from civil society and others, but I decided to go. And I think to start pushing the right question, to put the challenge in front of people, to make sure that the politicians start asking themselves why in 2014 you have almost 100% of people on treatment in Western Europe, when in Eastern Europe, Central Asia, you have less than 20% of people on treatment. Why we are seeing decline on new infection in Africa when we don't have a decline in infection in Eastern Europe? So I think raising those political questions seems sometimes naive, but push politicians more than any others issues.
Okay, that sounds a very good cue for me to sum up. And very, very, very briefly. I mean, formidable challenges, obviously. I must say, the most shocking thing that I found, I think, when I was doing my book, was that the figure that was quoted earlier in our discussion, half of the 35 million people with HIV are not diagnosed, half of those. And now that is, and it makes Michel's point, that is, I think, well known to an audience like this, but almost totally unknown, I would suggest, to political assemblies throughout much of the globe. And, I mean, it just does heighten and light up the challenge that there is there. And one of the major reasons for that is the level of discrimination, which was the other really shocking thing that I found out, the level of discrimination, prejudice, stigma that there is, not just on gays and lesbians, but also on the point that was being made on drug users, on sex workers, and on transgender as well. And that is something that just has got to be tackled by politicians. It's not just a question of illegality, although obviously it doesn't help remotely that you have, what, about 80 countries in the world where homosexuality is actually illegal, but it is the attitude as well as many of the populations in Russia, in Eastern Europe, and in Asia. So we have formidable issues to face, formidable priorities underlined by the Ministers of Health for Malawi and Swaziland as far as young women and children are concerned. And I thought what Deborah said at one point, we have many of the tools now, I mean, we really do have many of the tools, but we need the will to take it forward. And I so much agree with Michel that much of that will is a political will, and it mustn't be allowed, and I suppose I speak here mostly in European terms and West European terms, it mustn't be allowed to drift off the agenda, because that would be absolutely fatal at this point. So I would like to thank very much all the speakers. It's started after Michelle's outstanding introductory speech. It started off to a good morning, but thank you very much indeed for all your contributions. Thank you.
Thank you very much. And don't forget to buy the book on Amazon.
Thank you all for the interesting discussion. We're going to break for 15 minutes. Coffee will be made available for 30 minutes if you need refills. So I'll urge you to reconvene at 5 minutes after the hour. Thank you.